Hi, I'm Dr. Malpani. I'm an IVF specialist at Malpani Clinic, which is online at www.drmalpani.com, and our clinic is in Kolaba in Mumbai. And today I'm going to talk to you about sperm production. The fancy medical word for this is spermatogenesis. Now, we all know that sperms are produced inside the testis, and inside the testis you have all these tubules, which are called seminiferous tubules. And these words sound a little intimidating and complex, and I understand that. But if you stop to think about it, they're really not. Where the sperms are being produced is called seminiferous tubules. And the process of sperm production is called spermatogenesis. And if you looked at a seminiferous tubule under the microscope, and how do you do that? And the doctor does that by actually taking out a little bit of tissue from your testis. The procedure for that is called a testis biopsy, and sends it to the laboratory where the doctor does a histopathological examination so he can check for whether spermatogenesis is occurring or not. A testicular biopsy is a remarkably simple procedure. You basically make a small little cut and take out a little bit of tissue, often done under local anesthesia, not painful if it's done well. The point is that it needs to be done extremely rarely. A biopsy is only done for patients with azoospermia or a zero sperm count. There is absolutely no reason to do a testis biopsy for any other patient. So the doctor removes this tissue, sends it to the laboratory in a special fluid called Bowen's fluid. Again, all these things are important. Lots of doctors take shortcuts, don't understand, tragically don't even know how to do this properly. And then this particular tissue is sent in Bowen's fluid, which is a bright yellow colored fluid, where the pathologist then makes blocks and checks under the microscope. Now, checking the testicular biopsy is not easy to do. Lots of doctors don't even bother to do it properly. And that's sometimes why the results are so difficult to interpret. And that's why whenever you send the testicular tissue for a biopsy, please make sure it's done by a good urologist or a good andrologist who knows how to do these biopsies and sends them in Bowen's fluids, and is interpreted by a pathologist who understands what to look for. Because the seminiferous tubules will always contain some sperm precursor cells, what are called spermatocytes or spermatids. We want to know whether there are any spermatozoa present or not. And it needs a very detailed examination, because sometimes 90% of the seminiferous tubules may not have any sperm production, but 10% may. And that makes a world of a difference. Why is all this so important? Because patients who aren't producing sperms are called azoospermic patients. Now, in some of them, the problem is simple. There's a block, what's called obstructive azoospermia. In those cases, it's easy to find sperms. We can find sperm from the epididymis, what's called a PISA, or we can find sperm from the testis, what's called a TISA. But what happens for patients with non-obstructive azoospermia? These are the patients with testicular failure. And the testicular failure could be of two kinds: complete testicular failure where there's no sperm production, or partial testicular failure. But which is which really matters. Now, the trouble is a lot of doctors take shortcuts. They say they're doing a testis biopsy, but they don't. They do what is called an FNAC, or a fine needle aspiration cytology, which doesn't even require a cut. They just suck out cells from the testis and send that for examination. That's much easier to do, obviously. Anyone can do it because you just need to suck out. But the trouble is that if you find sperms, you know that sperm production is there. So it's reliable if sperms are found. But if sperms are not found in the FNAC, that doesn't tell us anything useful, because the doctor is not checking for tissue. He's checking for cells, and that's not as reliable. And this is why you need to understand what a good urologist or a gynecologist or an andrologist will do when examining your testis. Remember, if there are sperm in the semen, you don't need to bother about examining the testis at all. It really doesn't matter, because what we're going to do is work with the sperms in the semen. And that's usually what the IVF lab does, and that's what the embryologist does in the IVF lab. But if there aren't any sperms at all, then we need to find out what's happening in your testis. This is called an orchidometer, and this is what a normal testis, little egg-shaped structure, this is what the normal size is. And this is usually about 20 to 25 ml. So the doctor will feel it, compare it with this. Now, just because you have normal sized testis doesn't mean that you're producing sperms normally. The only way to find out if sperms are being produced in the testis or not is by doing a biopsy. You cannot take shortcuts. This is a normal sized testis. And this is what a small testis would look like. And here the volume is much smaller, and you can actually read the figures. So this, for example, is a much smaller testis. It's only about 8 ml. Now, the interesting thing is we can find sperms even in an 8 ml testis. But the trick for that is that the doctor needs to do multiple testicular biopsies, what are called microbiopsies. Why microbiopsies? Because you don't want to take out large chunks and damage the testicular tissue. And why multiple? Because sometimes one area may not have sperms, but another area may. So that you ideally want a doctor, when they're doing the testicular biopsies, will do multiple microbiopsies, preferably at least 2 or 3 from both the testes to find out whether sperms are being produced or not. Ideally, all this tissue should be processed in the histopathology lab, where the doctor can actually give a definitive opinion, and in the IVF lab, where the embryologist can see whether he can retrieve sperms or not. And if there are sperms in the histopathology report, we will definitely be able to find sperms on the TISA in the IVF lab, provided it's a good IVF lab. And this again brings us to the fact that TISA can be done in 2 different ways. One, as I described, was the diagnostic procedure where you do the biopsy and send it for histopathological examination. But far more valuable is the therapeutic TISA, which the IVF specialist does in the IVF clinic itself, so that this fresh testicular tissue is then sent to the IVF lab, where the doctor checks it to see whether he can retrieve fresh testicular sperms or not. The problem is lots of doctors don't do any of these procedures properly. And while it's easy enough to do a fresh testicular TISA, it's also easy to do it badly. And lots of doctors will and take shortcuts like doing an FNAC and say, sorry, we didn't find sperm. When the actual truth is there are sperms in the testis, but the doctor wasn't able to extract them. And you don't want to let that happen to you. The great advantage of a diagnostic TISA is you don't need to spend on an IVF cycle. But the disadvantage is, just because you got sperms in the diagnostic TISA doesn't mean you will necessarily get sperms in the therapeutic TISA. And plus, obviously, the disadvantage is you need to do the procedure twice. What some clinics try to do is freeze the testicular tissue which they get out during a diagnostic TISA, but our ability to freeze testicular tissue is not great. And the problem with the frozen tissue is that all the testicular sperms are then frozen, which means they're immotile, which means they're not sure whether they're dead or they're alive. I know this sounds complicated and your different doctors may give you different opinions, and that's why we strongly encourage you to go to www.drmalpani.com, watch the videos we have, watch what a TISA is, what's the right way of doing it, and the more you understand, the more you'll be able to make sure that you get high quality medical care. So you can get a lot of information therapy for free on our website, and if you have more questions, send me an email through the website. I'll be happy to provide you even more details. And if the information therapy helps you to have a baby, nothing will give me more joy and pleasure, because the reason I became an IVF specialist is to help infertile couples like you to have a baby and to complete your family. See you online.